having the first session about drug and alcohol services, how to refer in, and the support that is offered to patients that are struggling with drug and alcohol issues. Then we're going to have a short break for about 15 minutes at about 2:45 till 3 o'clock, and a tea and comfort break. And then after that, we've got some lifestyle medicine. And it's just to make you aware, the first half is being recorded, but the second half after the break, it's been asked if we don't record. So if you want to learn about lifestyle medicine, it's really important you hang on right to the end too, because that bit of the session won't be recorded. So I think our speakers for the first session have arrived. So I don't know if you would like to put their cameras on and I can introduce you. So I'm really pleased to welcome for the first session, we've got Donna Meredith Wood, who's Connor Operation Director, got Emma Roden, Service Manager for the Back Connor, and Lucy Jones and Denise Lloyd. So Lucy is clinical lead for the charity With You, and Denise Lloyd is also a senior practitioner with You. So I will hand it over now to those professionals to take us through the first half of the afternoon. Me and Lou are going to be monitoring the chat. So any questions, we'll try and collate them, and hopefully there'll be time for your questions at the end of the presentations. So over to you.
Thanks for that, Donna. Hi, everybody. I think we've gone a little bit rogue on the attendees, so sorry about that. So I'm Vicky Nash. I work for With You, and I'm the head of service delivery from CDAS. Donna wasn't able to make it today, neither was Lucy, but I've got Emma with me, who you've already introduced, and we've got Denise, who's also here as well. She's downstairs on a different screen. Please bear with me while I share my screen, because Teams is not my usual mode of communication, where we usually use Google Meet. So just bear with me and I'll share the screen. So we have got a presentation.
Yeah, we can see that.
Is that working? Lovely.
Yeah, thanks.
Thanks very much. So thanks for having us. We're really happy to be here. So myself, Emma and Denise, we all work for CDAS. So that is Stoke-on-Trent Community Drug and Alcohol Service. It is a different provider for Staffordshire, which is STARS, but we have got a slide on here just to tell you how to refer and get in touch with STARS as well. But the majority of the information that we're going to go through is relevant to Stoke, but we'll make sure that we circulate the slides as well after, so you've got them if you need them. So who are we? So we are Stoke-on-Trent Community Drug and Alcohol Service. We're commissioned by Stoke City Council, and we run the service. There's two organisations that run the service, that's With You and BAC O'Connor. So we run the service as a one provider model. We work as one team, but we have the expertise from both organisations to run the service. So we're here for anybody that lives in Stoke-on-Trent that's got a drug or alcohol issue or needs support, or anybody that has been affected by somebody that's got a drug and alcohol issue. It's really important to us that we're not here to judge. We want to empower people. We want to make sure that people can take control of their journey. And alongside that, we're not here to tell people what it is that they should achieve. So some people might come to us and think, I'd like to completely stop using drugs and alcohol. That's great. We'd support them with that. But also some people may want to just reduce or control their use. And that's also okay. We would support somebody to achieve that. So that's a little bit about us. So in terms of, we have a contract with the council. We've been in Stoke since 2024 in the current model, so April 2024. And we've got a contract for 5 years with an opportunity for 2-year extension. So we're just over a year and a bit in. So I've got a little video to show you, and I think we wanted to put this in at the beginning because I think it's a really, really nice way to frame really why we're here and what it is we do and the difference that we can make. So hopefully the sound works on this. If you can't hear this, if somebody could shout up and let me know, that'd be great.
It was horrendous. It was the darkest place I've ever been in my life. I was hopeless, helpless, lost. I had no dignity. I lost all my self-worth. I was homeless. Lost custody of my son, and I was addicted to a lot of substances, including heroin, monkey dust, and crack, and alcohol. So it was just, it was no way of life. I didn't want to live, but I didn't want to die at the same time. It's hard to explain, even though I did try and commit suicide 3 times. So I just didn't see a way out until I got help with CDAS. Got the support every day from one of the workers there. He's basically saved my life. So every day I would ring him and he'd answer the phone and speak to me and guide me through. So I got every bit of support that I needed. I wasn't alone no more, because I had to cut everybody off. And with CDAS, I wasn't alone, and he understood, he listened, he guided me through even coming off alcohol, trying to do that as well. And that's all I needed, that support, someone to listen. I would 100% be dead. I wouldn't be here. I could actually get emotional because it was that bad. I was in a right mess. I was on death's door, using every drug under the sun, living on off and on the streets, in a homeless shelter. Bad things happened. I was with bad people, and like I say, I didn't see a way out without CDAS. So, I basically owe my life to them. Just that, basically, I'm so happy with CDAS for believing in me, getting me into rehab. That was a golden ticket for me. I thought rehab was only for people who had got a lot of money. I never thought rehab was possible. If I'd known that before, I'd have certainly gone for it. So I was just forever grateful to have that opportunity, because I've got all the therapy, all the tools that I needed to take into recovery with me. So again, BAC, CDAS saved my life. Serene, peaceful, happy, elated, dream life. Because I might not be wealthy as in money, but I've got all the wealth. I'm rich with what I've got, which is my family, my job, my friends, and my recovery.
Thank you. So just to let you know, that the lady in the video there, we've not had much residential rehab funding in Stoke for quite some years, and a few years back we secured some funding, and Celeste, who you've seen the video, came into service, and we managed to use that funding and secure a place in our detox unit and rehab in Burton, which she completed. She then went on to live in one of our recovery houses in Burton and did some volunteering for us. We then gave her some paid employment as a cleaning lady in our tea rooms, our social enterprise in Burton, which she did for a few months. She later returned a few months after to Stoke-on-Trent and started doing some volunteering work for us here at CDAS, and she's just progressed and excelled, and she's now one of our recovery workers. So she's using her lived experience and her experience to make that recovery visible in Stoke-on-Trent and give back and support our service users. So I just thought it was really important to point that out, how far she has progressed throughout treatment with us.
Thanks, Emma. I think it's a nice reminder about why we're here and why
It was horrendous.
Oh.
It was a dark.
Sorry for that. We don't want to listen again. There we go. So we have a couple of locations that are fixed locations across Stoke-on-Trent. So we have our treatment base, which is at Whittle Court. So that is a lovely new building. Some of you may know it used to be where Brighter Futures were on Whittle Court. So we've had a nice refurb and we've got a lovely new building there. We've had some really nice feedback from clients. It's a really nice, welcoming, trauma-informed environment. We've got a office at Birch Terrace, which is a designated alcohol-only building. So we see a lot of our alcohol clients there. We do a lot of our group work there, and some of our nursing colleagues work from there as well. We see people in community venues, so we do lots of outreach. We come to some GP surgeries, so hopefully there's some familiar faces. We go to family hubs, And then we also do hospital in-reach. So in terms of how somebody would access our service, it can be through any way. We're not fussy. We'll help anybody that needs it. So that could be a self-referral, so somebody could call us up and we would arrange for them to be seen. We have started a new drop-in service recently, so that means that people can just drop into the building and see us during our drop-in times, and they can access treatment that way. We also accept referrals, and that's from any professional, so anybody can make a referral into service. We have some referrals that come through from a criminal justice pathway, so that may be people that are mandated by the court to attend. And we do a lot of work with community organisations as well. So yeah, anybody can refer. So this is a little bit of information about our drop-in service. So it's quite new. We changed to a drop-in model from the start of July, and it's been really successful. So we've had a 200% increase of the number of people that have accessed the service and been assessed and engaged in service since then. So we're hoping that that shows us that it's working and it's a good idea. So this is just for adults. So for an adult to access the drop-in, they can come to Whittle Court Monday to Wednesday between 9:30 and 2:30, or on a Friday morning between 9:30 and 12:30. And our team will be there to speak to somebody, give them advice, get them started into treatment if that's what they want. So it's a much more flexible approach. It's much more person-centred. I think the thing that we've really noticed is that because it's instant access, you're kind of meeting that person at their point of motivation, and I think that can make a really big difference. So this is some information about STARS, which is the Drug and Alcohol Treatment Service for adults and young people in Staffordshire. So again, people can make a self-referral, or professionals can refer into inclusion. So the link to the referral form is on this slide. Like I said, we will circulate this at the end. People can also refer to Chase Recovery or Better Way Recovery in Staffordshire. And then referrals to BAC are completed by the STARS partnership. And there's their contact details, so I'll make sure that that's circulated. And I'd really encourage you as well just to take a couple of minutes to have a look at the website there, because that will give you a lot more information as well. So we're going to talk to you a little bit about the different teams in our service. So we have, much like yourselves, I would expect, we have kind of sub-teams that have areas of specialism within the team. The client coming through treatment probably wouldn't be aware of this, but this is just, we wanted to just let you know kind of some of our specialist areas and what that looks like. So I'll talk to you a little bit about the drop-in, sorry. So our prevention and engagement team oversee managing all the referrals, managing the drop-in, and completing assessments for people that come in. So that's so we can get all the information we need to get to make sure that we can formulate a treatment plan for that person. They also have a really big focus on brief interventions and harm reduction. So they would make sure that not everybody that comes through needs treatment. Sometimes somebody's just going to want a conversation. They're going to need a referral to another service or signposting. We do a lot of training to professionals, and this team would also oversee that. So they may go out and do an naloxone training session to somebody, or do a presentation a little bit like this to different teams. So that team's really expert engaging people and doing brief interventions. We've then got a needle and syringe programme. So this means that we give equipment out to people that are injecting substances. So that could be anything from opiates to steroids. We will give out equipment including needles, barrels, spoons. We can provide water if needed, and anything else that's associated with that. So the reason that we do that, it's kind of well researched about the impacts that needle and syringe programs have. Some of you may remember it as a needle exchange. So they're not called needle exchanges anymore, they're called needle and syringe program. And the reason for that is Previously, guidance was that we would only give out clean equipment if used equipment was returned. However, there was some research into that showed that that was restricting the amount of clean equipment going out into communities. So it is no longer an exchange, in that we will give equipment out to anybody that needs it. So some of the things that we do in the needle exchange, we try and engage people into treatment. So the purpose of it is to keep people as healthy as possible whilst we're doing the work to engage somebody in treatment. Got some statistics that I hopefully really illustrate the benefit and the reason for needle exchange. Oh, there you go, needle and syringe program, sorry. So we know that it prevents bloodborne viruses. Studies show that needle and syringe program, when combined with opiate substitute therapy, reduces hepatitis C in people who inject drugs by between 50 and 60%. So we absolutely want to reduce bloodborne viruses in Stoke. We want to micro-eliminate hepatitis C, and needle and syringe program is a really important part of that. We know that by giving people that clean equipment and access to that clean equipment, we reduce sharing of equipment, which reduces the risk of people contracting HIV and hepatitis C. We also know that overall it's a cost-effective model. So we know that the healthier we can keep people reduces the cost elsewhere, usually in the health service. So there's some really nice examples of this. So there was some economic modelling done in 3 UK cities. So it was done in Bristol, Dundee and Warsaw. And it showed that continuing to provide a needle and syringe programme leads to long-term cost savings. And I think the most stark example of that was in Dundee, where it showed that it saved £2.5 million in the long run. And then additionally, they looked at quality of life and quality adjusted life years. And it showed that in Bristol, there was a gain of 502 quality adjusted life years. And there was an increase of 192 in both Dundee and Warsaw. And we know that it works. So in 2011, when Greece was going through its economic crisis, needle and syringe program was drastically reduced in the country, and in some places it was completely removed. And very quickly, HIV cases and the prevalence increased. And the studies show that there was a 1,500% increase in HIV cases after that reduction in needle and syringe program. So we know it works. There's loads of research, and we want to make sure that we're keeping people in Stoke-on-Trent as healthy as possible. Obviously, our end goal, we always hope that that person is going to engage into treatment, so we can help them hopefully reduce or stop their drug use. For some people, that takes a really long time, and for some people, that's far quicker. But we're there to kind of offer advice around how to inject safely, how to reduce harm, how to keep themselves safe. We'll give safer injecting advice. Another really important part is giving out naloxone. So I'm sure you all know what naloxone is, opioid reversal. So it can help reduce overdoses. So we make sure that every client that is willing to have it does have it. We can also offer that to professionals. So we train lots of partner organisations in naloxone provision, and we can provide it to you as well. So if that's something that you're interested in, please reach out and we'd be happy to come and do some training. We know that carrying it saves lives. We've got a number of examples where naloxone has been used and it's reversed an opioid overdose. So we also support young people as well as adults. So we support young people from the age of 5 up until 25. So if we've got somebody that we feel sits better in the young person service but they're over 18, we can do that. So we can tailor the interventions and the support to that person's need. So we offer support via a mix of one-to-one and group sessions, and we also deliver some school-based programs. So for our young person support, it is fully community-based. So we would always go to the young person, So we do a lot of our sessions in homes, in schools, in youth clubs. So those things are really important to us. We have a transitional worker who specifically supports people in that 18 to 25 range. And we also have a mind and body practitioner. So that's quite new for us. But Mind and Body is a programme that supports young people who are suffering or struggling with self-harm. And we go into schools and deliver that programme in schools. And then we have a family support team as well. So this is quite new for us. We're still recruiting to some of the posts in this team. But we offer tailored support to families who have experienced substance misuse. So this could be the parents of somebody and the young person, or the other way around. So we would deliver family sessions to help parents understand the impact of their substance misuse on the child or the young person, and to support the young person with their understanding and any concerns that they've got around that. So we're working really closely with family services, and we're out in the family hubs. We're really looking forward to getting the data for this to see what difference it's made. But as I said, it is quite new for us still. We also have a criminal justice team. So I think I spoke a little bit about this at the beginning in terms of the referrals. So some of the people that are supported in that team are people where they've been court ordered to engage. So they may have an alcohol treatment requirement or a drug rehabilitation requirement. So that's when they have potentially been charged with an offence that's related to a substance issue. And then they're asked to engage with us for a certain amount of time. And we use that opportunity to support them, identify their goals and support them through treatment. We also support people on release from prison. And we work in custody, where people who may test positive for a substance when they've been arrested, we can offer interventions at that point as well. And then I think this is the last one from me. So we have an assertive outreach team who we use to try and engage people that may have complex needs. So this could be people that are homeless, it could be people that have got lots of different needs, and they may struggle to engage in treatment from the other methods. So we work on an outreach basis and we tailor that support to that person. So we would do all the things that we've just discussed. So triage and assess, offer harm reduction, offer needle and syringe programme, and naloxone training as well. And the aim of this team is to really go out and see people where they're at, and look at what we need to change and do differently to help that person get into treatment. I'm going to hand over to Emma.
Okay, so we've got a range of, as Vicky said, of different teams, but the majority of clients probably sit within our care coordination part of the service. So as Vicky's already said, we do work from a variety of different locations throughout the city, and not just from our main bases. So our treatment model, we've got a really, really strong focus on outreach, and we're continuing to increase the number of venues that we work from within the city. And the reason is our aim is to make treatment more accessible for people to engage with us, and ensure that they're getting the right support at the right time by the right team. So we've got quite a big staffing team. They're all multi-skilled staffing team, and they've got a range of knowledge and backgrounds. We are very big on employing people with lived experience, because we want to make that recovery visible throughout our services. So once somebody's come into treatment and they've completed a full assessment, we can then identify their individual treatment needs and the support that we need to put in place. So each client's then allocated to a recovery worker, and we then use person-centered approaches and work with the client to draw up a care plan, which is, it promotes client choice. So each client's invited to attend regular one-to-one sessions, as well as group work, where the recovery workers and the group workers use a range of psychosocial interventions, such as motivational interviewing, solution focus techniques, CBT techniques, which are all evidence-based, and we know that these techniques work with our cohort of clients. So we also provide harm reduction, advice and support to all our clients, and that's allowing them to make informed decisions about their drug and alcohol use. We've got a certain element of funding allocated to inpatient detox and residential rehab. Unfortunately, it's not an endless pot, so we do try to work with people very, very closely that's a treatment option for them, and that's to prepare them. Our rehab programs are really the 12-week, and they're really intense programs with a lot of therapy, so we try to support the client as best as we can to make sure that that option would work for them. Okay, so within CDAS, we've got our own housing support team. It's been funded through a separate grant that we received, and it's one of the newer teams within the service. We're in our 2nd year now, and the team has grown a little bit with some extra staff, which is fantastic. So within that team, we offer specialist housing support to any of our clients who are experiencing homelessness or any housing issues, and this is in addition to the support that they're already receiving elsewhere in the service from whichever team they're working with. We work really closely with a company called Concrete, which is a housing provider in Stoke-on-Trent, and we've got access to 16 bed spaces within some of their properties due to this grant. They're all full at the moment, so they've been really well utilised, and the clients are really well supported. So the team offer a range of interventions again to support the clients to find safe and stable accommodation. And once they are housed, we will then continue to work with them for periods of time to support them to sustain the tenancies. So within that team, we've got some different staff that include floating support workers. We've got a housing officer, we've got peer support and diversionary workers, and we've got some lived experience workers. And we've also got a personal budget that sits alongside this grant, and that's fantastic because that allows us to support clients in with meaningful activities and use of time, and allows them to gain interests. Okay, and then we've got a rough sleepers team. So we've had, again, this is a team that's grown over the years. We're in our 4th year with this team, and I mean, it's great to have this. This team provides real specialist outreach support to clients who are rough sleeping or at risk of rough sleeping. These clients tend to have a lot of complex needs, so the caseloads are much lower than what they are within our core services, so we can really provide that intense support to people. So within the team, again, we've got a range of staff from recovery workers, we've got dual diagnosis workers, we've got a dedicated women's worker and a nurse prescriber. We've also got what we call an NPS worker, so that's a novel psychoactive substance worker, and primarily works with clients that use MDP, HP, or perhaps better known as the street drug monkey dust. So again, those clients are quite complex, and the worker sits on a very low caseload, so we can really put that intensive support in place and support them not just with the drug and alcohol use, but also with the range of other issues such as the physical health, the mental health, housing, finances. So we do as much as we can, to support those clients. We run a weekly breakfast club on a Friday morning from 8 till 9. That's quite well attended. We offer, hot drinks, warm drinks, and food. And we tend to have an assessment worker that sits in during that time. So if any clients do come in, we can assess them straight away and look at, which avenue of treatment that we put them through. The team, as I say, are purely outreach. They're visible on a daily basis throughout the city, working literally on the streets, but also from community lounges, hostels, lots and lots of places. They're out every day, working with the clients on their caseloads. We also hold medical reviews and prescribing clinics for this cohort within the community, and we've got a real focus on a joint approach. And we attend a lot of MDTs to put this wraparound care and support around these clients that are so complex. And then Stoke Recovery Service, so better known as SRS. So this is our recovery service service, and this part of the service is for clients who are abstinent from illicit substances and alcohol. Up until we won the new contract last year, SRS was primarily for clients that were completely abstinent from, you know, prescribed substances as well as illicit and alcohol. However, we kind of made a few changes and opened the doors just to build that recovery community and build on connection and motivate some of our clients that were in treatment at CDAS. So we now accept clients that are prescribed from our services but are not using illicit drugs and alcohol, and that's been really well received. You know, the attendance has really increased, and we are visibly building this fantastic recovery community over at SRS. So again, we offer tailored support that's person-centred to support people's aftercare and sustain their recovery, and that comes in the form of one-to-one sessions or group work. So we've got qualified therapists that work from that service, and they offer a 12-week course of psychotherapy to support clients that are abstinent. We cover lots of core subjects group-wise, such as relapse prevention, and we do some motivational support. We've got a men's group, a women's group. We do lots of things, arts and crafts. We've got a regular weekly fishing group, which they're out today in the pouring rain, but they still come and they still attend. And then we do some social activities. So we've got, you know, we might have a cinema trip or a bowling trip, and when the weather's a bit better, perhaps a picnic or something in the community. And we also utilise Noreen's Recovery Lounge, which, for anybody that doesn't know, is our social enterprise that we run out of Fenton Manor Sports Complex. So the idea of our social enterprises are that, one, it's a safe space for some of our staff to take their clients, where we can give them something to eat or drink and you know, complete their one-to-one. We have held quite a few groups there for clients, but it's also open to the public. Away from and the reason that we're there. So we have some paid members of staff, but we also employ some of our clients that have been through our services here or been through residential rehab with the BAC. They've lived in our recovery houses, and we support them through. So some come and volunteer, but some we've given paid work to. And the idea is to bring people again back into the community, give them skills. Some of them have not worked for such a long time. Some have worked in very different kind of areas of employment and have never worked in a cafe, but it's quite amazing when you see, you know, the confidence and the self-esteem and things building. And again, it's about having that support and that connection. So it's a really fantastic place, and I'd encourage you all to, if you're around Fenton Manor, pop in and see us sometime. We've also got a family group that we run from SRS on a Tuesday evening, and that's to support carers, family members, concerned others that are affected by, you know, a loved one or somebody's substance misuse. The client or the person that they're supporting doesn't have to be in treatment with us. We welcome everybody that needs that support for themselves into that group. And SRS, we also, AA uses that service on 2 evenings a week as well for mutual aid. So as I said, we've got and we're continuing to build this really, really strong, you know, visible recovery community in SRS, which is great.
Yeah, and I think it's important because the one thing we know from a lot of our clients that come in, community is important, and I think to have that community and somewhere that you belong when you're making those changes, that's what makes the difference between someone being able to sustain the changes and not. And we've heard that really clearly from clients, haven't we? Yeah. And also, if you've got sweet tooth, the cake there is very good. I would highly recommend. Thanks, Emma. So Denise is going to take over now, and she's going to talk to you a little bit about our clinical team and some of our clinical or pharmacological offers that we have in service.
Hello everybody, so I'm Denise, the senior non-medical prescriber here at CDAS. Obviously for the purpose of the presentation, it's been split into clinical and recovery side of it, but we do work as one big team. So obviously some of the things I'm going to go through have been touched on already. Emma and Vicky have covered some of it. So I don't want to repeat myself, but it's just so we can separate the clinical and recovery, but it is all one big team and done as a big team. So as you can see from the clinical team, we've got a clinical lead, we've got 5 NMPs, non-medical prescribers, 3 substance misuse nurses, 2 healthcare assistants. So we've got quite a varied team. We've got a couple of new staff joining the team as well within the next month, so that'll be great. So so I know Vicky's touched on a lot of this, but obviously as a clinical team, our commitment is to just ensure that we deliver the best care we can. We try and ensure that that care is always evidence-based. It's really important that we remain compassionate, non-judgmental, empathetic. We aim to reduce harm and tackle health inequalities. Again, I know this has been mentioned earlier, and just basically to help people live healthier, happier lives by moving barriers to the support. So as you can see on this slide, this is a lot of the clinical interventions that we provide. When you put it down on paper, it is quite a lot. So obviously we do specialist alcohol assessments. Now these can lead on to detox. So we do inpatient detox and referred inpatient detox, and we also do some community detoxes. I'll talk about that in a bit more detail a bit later on in the presentation. So we do relapse prevention, medication and advice. A large part of what the non-medical prescribers do is obviously opiate substance treatment, so substitute treatment. So them are things like your methadone, buprenorphine. We've recently introduced Buvidal. A lot of BBV detection and treatment, which again Vicky's touched on with the needle exchange, vaccinations, phlebotomy, ECGs. We do fibre scans. We're very fortunate here at CDAS that we do actually have 2 fibre scans. So we do run weekly clinics, and these are absolutely great for clients with alcohol-related concerns or some of the Hep C clients. So we can actually carry out the fibre scans ourselves, and also clients, we can take them out into the community as well. So some of the fibre scans are done in the client's own home when they're assessed by the substance misuse nurses. We do advise on basic wound assessment and harm reduction. As far as the wound assessment, we do have a lot of our outreach venues that we go to. They have what we call the COV nurses there, and they deal with a lot of the wound care. So although we would give advice, that's sort of really carried out by the COV nurses. As Vicky's mentioned, we do the needle exchange, the naloxone, and also as Emma mentioned, we do a lot of outreach. So I cover a lot of the outreach. I work a lot with the homeless. So we do set clinics, and we also I go out to a lot of the hostels. So we have the non-medical prescriber who deals with all the homeless. So she sees them at sort of particular venues across the city. I'll go out to a lot of the hostels, and I also see some of the core clients who've got quite serious comorbidities that can't get into service. For example, I've got, a client who's paraplegic and clients who are wheelchair bound. Obviously it's harder for them get into service and see us. So I sort of take them on my clinics and go out and see them. And as Emma said, it's about us getting the service to the client a lot of the time. Yeah, next slide. So as we've touched on earlier, really big drive at the moment on Hep C and BBV. We're aiming to achieve micro elimination, so we've got a real big drive on it. So all clients are routinely offered dry blood spot tests, which will test for Hep B, Hep C and HIV. We work closely with Royal Stoke Hospital, and I'll talk about that in a little bit more detail. And we also have a dedicated BBV nurse here in a healthcare. Well, actually, we've got 2 healthcare workers now, so they can get out into the community and also sort of based here at Whittle Court. Yeah. So when the clients obviously have the dry blood test, it normally takes about 2 weeks for us to get the results back. The results are emailed over to us. So at that point, when the nurse has found out that the client's got Hep C, we would get in touch with the client. A lot of the time we'll try and tell the client face to face, because sometimes, you know, it can be a bit overwhelming for the client to find out that they have got Hep C. Then we'll collect the results, we'll do bloods if needed, we'll do a fibre scan if needed, send the results off to you, the GPs, and also get in touch with the Hep team at the Royal Stoke. We have a weekly MDT with the Royal Stoke every Monday, where we're with the specialist nurses and one of the Hep doctors there. So then we'll devise a plan. They'll prescribe the treatment. Within 2 weeks, we'll go collect that treatment, and then we'll support the clients through their treatment. Now, obviously, there's a few options with the treatment for Hep C. We've got 8-week treatments, 12-week treatments. So we do, when we have the MDT, we do try and tailor the treatment around the client. So obviously, some of the clients are more chaotic than others. You know, the clients who are housed, that's great, but the clients who are rough sleeping. So when I say that we support them with the medication, sometimes it might mean that we have to do weekly drop-offs with the clients, because if they've got nowhere to store the medication, then we'll do weekly drop-offs where they get the we'll just take it out to them in the community, and then hopefully our aim is to not leave anybody behind, to get them all treated and to reach micro-elimination. So as I touched on at the beginning, we do a lot with alcohol clients. Personally, I only sort of do the opiate clients, but we do have specialty substance misuse nurses. So following a thorough assessment, all cases are discussed again. We have a weekly MDT meeting every Wednesday afternoon, and we also have a complex case reviews, which our clinical lead does. So once they've had the assessment, then a robust package is put in, and then obviously if the client wants, a plan for detox is formulated. So this would all be dependent on the client's needs. So clients can access, as I said, the community alcohol detox or the inpatient alcohol detox. We also do relapse prevention. So once a client's had a detox, obviously we don't just leave the client then. We keep a full package in place so we can ensure that they remain abstinent. The next slide. So the community alcohol detox. So basically, it's a supported withdrawal carried out safely in the client's home. Now, obviously, there's different criteria for the community and for the inpatient detox, but with the community one, obviously it's really important that they've got 24-hour care with them 7 days a week, because these clients, you know, again, safely sort of detox them off alcohol. So we've got 2 dedicated detox nurses. They'll go out to the client on a daily basis, twice a day, ensure the client's absolutely fine. So if you can move on to the next slide, Vic. That was just basically the criteria. I'm getting a bit ahead of myself. So the criteria for the home detox. Sorry, Vicky's controlling the. Yeah, anyway. So the person has 24-hour care. That's really important, obviously, because they may have some side effects from the treatments, and again, you know, if you need. There's no current drug use. We do accept clients who are on methadone for the home detox, but it wouldn't be on a dose higher than 70 mils. So clients who are not suitable for the home detox are patients who've got diagnosis of epilepsy, because as we know, there's risks of seizures when you're withdrawing from alcohol anyway. Patients who've got type 1 diabetes. Obviously, as I said earlier, patients with no fixed abode, because it just wouldn't be doable for do this out into the community. And then patients whose blood results aren't too significant. Next slide, please. So how does it work? So initially the client will have an assessment, and that's across 4 domains. So it's alcohol and drug use, medical history, they'll have blood tests, they'll probably have fibre scans, because at the moment we have over 400 clients, I think, sitting in CDAS with ADSI scores of above 20. So all these clients would sort of fit the criteria for having a fibre scan anyway. They're reviewed at the weekly MDT, and there's also nurse prescriber input. So we have one of our substance misuse nurses who is solely she looks after the alcohol clients and does all the prescribing for that. So they get medication support and daily nurse contact during the detox. As I said, they do go out to visit the clients twice a day, do regular observations, offer support as also to the carers, whoever's out helping the client through the detox. So then if the patient's obviously not suitable for community alcohol detox, then we'll do an inpatient referral. We have one substance misuse nurse who she sits with all the inpatient referrals. So as Emma stated earlier, we've got sort of different specialist areas what deal with the detox. So they're a clinical setting, which again provide 24-hour care. This is a medically managed withdrawal, so this will be, like I say, for the clients with more complex health needs, with comorbidities. So this is sort of ensuring that they're in a safe environment, and yeah, they're getting the treatment they need. And again, as I said earlier, when these clients have sort of had the detox, the inpatient detox, we would then follow that care pathway back out into the community and ensure that they're getting all the care they need after. So who is it for? I've sort of basically covered this, but the complex health conditions, obviously that would be the clients who definitely need the inpatient, the ones with no, sorry. Yeah, so obviously OST. So a lot of what the non-medical prescribers do is OST. So basically it's prescribed medications that help people to reduce and stop illicit opiate use, and I'm sure you all know what they are. The main 3 that we use are methadone, buprenorphine and Buvidal. So hopefully once you've got a client established on OST, we can reduce the withdrawal symptoms and cravings, help reduce the risk of overdose and other drug-related harms, and deliver a wraparound support to aid stability and recovery. You can move on, Vicky. A lot of our clients, obviously, as I was saying earlier, I deal with a lot of the homeless clients who are chaotic, so then we look at daily supervised consumption with the pharmacies. So who is it for? So basically anybody who is dependent on heroin or other opiates. So it doesn't necessarily have to be heroin users. A lot of the time we've got some clients who've been addicted to pain medication. So again, it's for clients who are motivated to stabilise and reduce harm, and those are at risk of injecting related harms, as you know, we've stated about BVV and all the things. So how does it work? So a lot of the clients refer non-medical prescribers usually within a week of the initial assessment. So then we develop a joint prescribing plan in collaboration with the service user. The medication's prescribed and the doses are reviewed regularly. A lot of the clients, as I say, initially when we first put them onto OST, we will do supervised consumption, which basically means they have to go to the pharmacy every day to collect their medication, and it's supervised because we don't want to put them at risk of overdosing or, you know, until we get the titration right. So usually when we first initiate a client onto OST, we'll do another medical review within 4 weeks, because it can take time getting the doses right, you know, titrating. That'll be dependent on how heavy their drug use is. Some clients need go higher, some clients need go lower. So we usually see them within a month. After that, we would see them at 3 monthly intervals, but we do liaise closely with all the recovery workers. And obviously, if there's any issues before the 3 months is up, then we'll see them sooner than that. So yeah, it's a lot of liaising, and yeah. So yeah, I'll hand you back over to Vicky now.
Thanks, Denise. You did a great job there. Sorry, I was a bit excited with the slides. So that is kind of the overview of our service. I suppose just to summarise, I suppose I'm trying to think of what the things that you need to know that are going to be important for you. So if you want to refer somebody into service, you have two options. You can complete the referral and send it to us. The information will be in the slides when we send it over. Or you can signpost people to our drop-in times. We've got loads of literature. We've got some really nice posters and leaflets. So we can absolutely distribute those amongst you if you think that would be useful and you want those in your surgeries. And hopefully we've given you a good overview of what we do, what we can help with. Pretty much anybody that lives in Stoke-on-Trent with the substance misuse needs, like we're here to help. And that is the same for Staffordshire as well. So I haven't been looking at the chat, but if anyone has got any questions, we have got time. So if you want to pop your hands up, please feel free.
Thank you all for your fantastic presentation. We've got a question from Fiona Riley. Are you able to offer psychological support for patients who are addicted to prescribed opioids? For example, if the GP agreed and prescribed a reduction plan for, say, oxycodone, can your service offer the psychological support aspect?
Absolutely. So yeah, we would work in conjunction with the GP and complete the PSI support alongside that. Also, if you did have any clients that were addicted to prescribed medication and you wanted advice around how you could support them with a reduction plan, our clinical lead would be happy to offer that support to you as well. So just reach out via the email. You can take my email, contact me or Emma or Denise. Yeah, absolutely.
Yeah, and there's a question because I was feeling this as well. I'm STARS, for those of us that aren't in Stoke-on-Trent, does STARS offer the same sort of services that you've just described?
Yeah, so they very similar. They will have different teams and different structures, but yeah, absolutely. Like they will have very similar services on offer. Yeah.
Yeah. And Sarah Rigby said some posters and leaflets would be very useful. They're based at Moorcroft and Hanley and Moss Green Surgery in Bentley. Have you got any things to put in waiting rooms at all?
Yeah, absolutely. What I can do is I will circulate. Well, I'll send. Is it okay to send to you, Donna, our electronic?
Yeah. So send it to Staffordshire Training Hub, and then then we could. Is that okay, Louise? We could put link. We could have it on the website, could we? Or
yeah,
how's that going to work?
Is post session I'll be putting this recording up on the screen as well. If you've got any presentation slides, we can share those, and then any extra resources I can add those in as well. So just to make people aware that we have got our own dedicated PLT page that covers all the sessions that we do, any recordings and resources, etc. So that's where you can access that information.
Definitely, and we can drop off actual leaflets as well. Yeah. So Emma's written down the request, so we'll follow that up. Thank you.
Yeah, thank you. And then we've got Laura Barraclough said that she's got some really good feedback from the drop-in sessions are going down very well. So it does sound a great idea. So well done with that. And then Ulka Sankey said, I wasn't sure about the service slides for children 15 to 18, and yeah, I was a bit shocked, maybe judgmental about 5-year-olds. Are there many children that get referred?
So when you're looking at that age, the 5-year-olds, that would usually be supporting them to deal with their parents' substance use. So we do it from both angles. We do it for a young person that's using substances themselves, or for a young person where a close family member is using substances, and we do a lot of child-based sort of play work with that child to help them understand and kind of process what's going on, how to keep themselves safe, how they could speak to adults and who they should speak to if there's concerns or issues. A lot of those children are coming in via social services referrals, so a lot of them will be open to social care, but not all of the time.
Yeah, okay, no, that makes sense. And it's a thank you from Sarah Rigby. I don't know. I saw Nick Aldridge had got his hand up.
Yeah,
Nick, do you want to come in?
Just who looks after in Stafford children and young people? Is it still Stars?
Yes, so Stars also offer the young person service.
Okay, thanks.
No problem.
So if
Any
we
more?
go.
Lovely. I think we got off lightly there.
Yeah.
It's really interesting. It's amazing what work you're doing, and obviously you've got a fantastic team delivering, really holistic care to sort of a really vulnerable group of patients. So it must be really challenging work, but also very rewarding, I'm sure. So I love the video, the lived experience. That must make it all worthwhile when you have patients coming out the other side. So well done.
Thanks,
Thank
Donna.
you.
Thanks for everybody.
Yeah.
If you do think of any other questions, just drop us a line. We are here to help.
Thank
That's
you.
lovely.
Thank
Thanks.
you.
Thank you.
Bye-bye.
Thank you very much.